Okay, so it looks like we can go ahead and get started. I'm just going to introduce everyone to everyone, and then I will let our wonderful presenters take it away. So, so first, well, I don't know if it's on the left or the right for you all, but we have Guadalupe Marquez-Velarde, who is currently an assistant professor of sociology at Utah State University with a focus on population health, social demography, and race and ethnicity. Her current research focuses on health inequalities among Black, Latinx, Black immigrants, and the LGBTQ plus community. Her work can be found in peer-reviewed outlets, including SSM Population Health, the Journal of Racial and Ethnic Health Disparities, Local Environment, and Environmental Justice. And we also have with us Gabe Miller today, who is a doctoral candidate and will soon be joining the faculty at the Mississippi State University in the fall as an assistant professor in the Department of Sociology and the program in African American Studies. Gabe studies he's a medical sociologist with research and teaching interests in health disparities, political and policy determinants of health, LGBTQ plus health, critical race theory, and racial and ethnic relations. So whenever you are ready, please take it away. Thank you both so much for joining us.
Great.
Thank you for having us.
Yeah, thanks so much for having us today. We're excited to be here with you all virtually and to talk a little bit about racial health disparities and COVID-19. Yeah, so as April said, my name's Gabe Miller. I'm a doctoral candidate here at Texas A&M University. And then my colleague Guadalupe Marquez-Velarde is at Utah State University. So we're joining you from all across the United States and real happy to be here today. So since early to mid-May, we've seen some increasing news coverage on racial health disparities and COVID-19. We've seen just some straightforward things about how COVID is disproportionately impacting racial and ethnic minorities and how it's having a differential impact between whites and groups of color. We've also seen some increased coverage on the impact of COVID among incarcerated populations. So this is something that we won't necessarily be discussing in detail today, but something that we felt should be acknowledged. We've also seen increases in localized stories such as African Americans making up all of Richmond's COVID deaths, as well as some challenges with racial and ethnic data collection as it has been seen with American Indians either being left out or labeled as other in the mortality statistics that are coming out at the state level. So authorities and the public alike often seem perplexed by the fact that Blacks, Latino and Indigenous populations are dying at higher rates than whites. But as medical sociologists, as well as other social scientists, we've long known and sounded the alarm to the fact that structural racism, that interpersonal discrimination, lack to access to healthcare, biases in clinical settings, as well as political and policy determinants are all harmful to the health of minority populations and result in many of the health disparities that we observe. So excess incidence, prevalence, or mortality relative to a group's proportion of the population is generally what constitutes a health disparity. A key distinction that we like to make between health differences and health disparities are that a health disparity occurs when there's some basis of social disadvantage, which results in differences that are unjust and unavoidable. So we've seen ample evidence of this among Black, Latino, and American Indian populations in the context of COVID-19. So as can be seen here on the figure on the right, of the 37 states and the District of Columbia that have accessible race data, a disparity exists in Black mortality rates, with the exception of 6 states. So Alaska, Vermont, Oklahoma, Washington, Arizona, and Minnesota all have lower mortality rate or lower mortality percentages than their shared proportion of the population. In Texas, where I am, African Americans make up about 12% of the population, but currently constitute about 19% of COVID deaths. In Mass, where many of you all are, 7% of the population is made up of African Americans, but around 11% of deaths. In Mississippi, where I'm soon heading, around 38% of the population is African American, yet 61% of deaths in Mississippi are constituted by Black populations. Utah currently doesn't have accessible race data for mortality, so we can't clearly say what's going on there. In New York City as well, there's some stark disparities in incidence, morbidity, and mortality. With all of these measures, Blacks and Latinos have higher case rates per 100,000 population than whites do. And we also know that African Americans make up a larger proportion of the impacted population than their relative population size. We also know that, as I mentioned, many states are not reporting on American Indian cases, or they're lumping American Indian cases and deaths into an other category. But there is evidence of disproportionate impact there as well. So in New Mexico, American Indians represent about 10.9% of the state's population, yet they constitute around 37% of COVID cases in the state. Additionally, if the Navajo Nation were a United States state, it would rank third in case rates and would only be behind New York and New Jersey. So it's evident from all of this that a racial disparity definitely exists in COVID. And with that in mind, it's definitely important that we understand why this is the case and what's going on. So policymakers and other government officials have attempted to explain the disparities that we're seeing by suggesting that high rates of comorbidities that are associated with COVID are to blame. So of all the US COVID hospitalizations through April 19th, around 56% of cases also had hypertension, 52% were obese, 41 had metabolic disease, and around 32% also had cardiovascular disease. So we've heard clinicians, we've heard policymakers, government officials, as well as celebrities and people in popular culture and the media all suggest that this is an opportune time to get a control of these comorbidities in communities of color, that communities need to rally and get control of their obesity, of their hypertension, and so on. So while it's true that communities of color are disproportionately impacted by many of the comorbidities that occur with COVID, it actually ignores why these groups have disproportionate rates of chronic illness to begin with. And we also are largely ignoring what real policies and politics have to play in health disparities that we see, as well as in responding to COVID. So from here, Guadalupe is going to talk a little bit about racial health disparities at large. I'll jump back in to talk about some political and policy determinants of health and some preliminary analysis that we're doing in this context.
Thank you, Gabe. So why do all these communities of color, mainly Black Americans, Latinos, or Latinx, and Native Americans or Indigenous people, why do they have more health conditions to begin with? So racial health disparities, they have always existed in the United States. They exist for most chronic conditions. They exist in terms of functional limitation and disability. And overall, especially for Black Americans and Native Americans, life expectancy and total mortality is lower. I mean, life expectancy is lower and total mortality is higher for these groups. So the early research on health disparity usually focus on biological differences across races. However, we know now, due to modern scientific research, that the categories that we know in terms of race do not really aggregate into any meaningful genetic variation. So all these categories that we use such as white, Black, etc., are social rather than biological, right? And these are the categorizations that have emerged from a system of stratification, of power, and they really do not represent a meaningful variation across races, across biology, and therefore they do not explain racial health disparities. So now most scientists reject the notion that health disparities have anything to do with biological differences. And the sociological study of health disparities in the United States began with the work of W.E.B. Du Bois. In his work in the Philadelphia Negro, he suggested that poor health among Black Americans had to do with the poor living conditions in which they lived compared to white Americans. And ever since Du Bois started this work, sociologists have continued to highlight that the social conditions in which people live, those are the ones who originate health disparities across groups. So as you can see in these charts, both African Americans, Latinos, and American Indians, they're more likely to have depression, to have a stroke, to have heart disease, obesity, diabetes. All these conditions that Gabe was mentioning, all these groups are especially susceptible. So how does race operate to produce health disparities? According to sociological research, racism acts at both the macro level and the micro level to affect health disparities and to produce these disparities vis-a-vis institutional discrimination and interpersonal discrimination. We also have issues of access to healthcare and a pronounced bias in clinical settings towards people of color. So one of the main mechanisms of institutional discrimination in the United States is residential segregation. Residential segregation, even though we have the equal housing, even though we have equal housing laws, it's still pretty much only slightly lower than it was during Jim Crow. It is shaped by local and federal de facto policies. It is shaped by how banks give out mortgage loans, how realtors and the real estate industry sort of shape shape their own practices, and they basically move people of color or they guide people of color only to live in certain neighborhoods. So residential segregation limits access to quality education, and because quality education is non-existent, that affects future employment opportunities. It concentrates poverty and social disadvantage. The most segregated group in the United States is Black Americans. And you can see in these maps that even though diversity in the United States is increasing, segregation is still pretty much present. So you can see in the maps, you can see portions of the maps where blue that represents Black Americans is highly concentrated in Chicago, in DC. You see the same with Hispanics, a little bit more scattered throughout Washington and Houston, but pretty much concentrated in Chicago. So you see, if you go to, if you look at segregation maps all over the United States, every major metropolitan area pretty much looks like this. All the groups are pretty segregated. And here's a map of Boston, and you can see the same. And you have the map on the left is 1990, the map on the right is 2016. As I said, diversity has increased, but you see still pretty segregated, the population is still pretty segregated. And you see a clear differentiation between where Black Americans live, where the white population lives, where Hispanics live, is still pretty demarcated. So why is segregation relevant? Well, because segregation, segregated neighborhoods are characterized by food deserts where people lack nutritious and affordable food. People have to commute considerable distances to go to an actual supermarket. There's a high level of advertising and sales of alcohol, tobacco, and fast food outlets. And there's no regulation in terms of the concentration of these types of businesses. There's poor infrastructure and institutional neglect. The housing is poor quality housing. There's no sidewalks, there's no parks, there's no safe areas for recreation. Areas where minorities are concentrated are also victims of environmental injustice. So they're also exposed to toxins, poor air quality, poor quality in terms of water as well as other environmental risks, such as having a landfill in the neighborhood or having some type of industry operating in close proximity to the neighborhood. Therefore, there's poverty and social disorder at the community level. So this puts the population in the neighborhood, it exposes them to chronic stress and hardship, right? If you see that your neighborhood is not well kept, that it's highly polluted, that it's actually very stressful at the community level. Of course, these properties in segregated neighborhoods have low property values, there's institutional neglect, and a lack of political representation. And again, low property values also has a strong relationship with wealth accumulation, because the main source of wealth for Americans is home ownership, right? And if your property has little value, that means that your chances of accruing wealth to benefit, the next generation, those chances are really low. So as we can see here in these graphs, poverty is pretty much concentrated in areas where Blacks and Hispanics reside. I don't have data on Native Americans here because it's a fairly small group. But as we can see, in city and suburban areas, we can see that a high proportion of Blacks and Hispanics are living in concentrated poverty neighborhoods. And concentrated poverty neighborhoods are defined as those neighborhoods with poverty rates of 40% or more. So 40% or more of the people in the neighborhood are under the poverty threshold. So how does segregation and how does concentrated poverty have to do with COVID-19? Well, early research in COVID-19 tells us that disadvantaged communities, where predominantly poor people and people of color, are having higher proportion of COVID cases, right? So this is San Francisco, and we can see in the map in the middle where the disadvantaged communities are located in orange. And when we see the map of COVID-19 cases, we see that those areas where people are more disadvantaged, that's where more cases are present. And we see the same in Milwaukee County and Chicago. The areas where more African Americans are concentrated are also having more cases and more deaths from COVID-19. So segregation really plays a really strong role in concentrating poverty, and in concentrating poverty, affecting the living conditions from education to what people eat to the opportunities to exercise, etc., that affect the comorbidities that make people more propense for having a severe case of COVID-19. Interpersonal discrimination, it's also another stressor. So not only minorities deal with stressors at the community level and sort of at the macro level, but interpersonal discrimination is also associated with poor health. It puts people at an increased risk of poor physical and mental illness. It's been associated with hypertension, with coronary artery calcification, with depression and anxiety. And it also affects how people use healthcare and if people adhere to treatments that the doctors prescribe. So if people perceive more discrimination, they are more likely to feel more stress in general. So yes, people are stressed because of segregated neighborhood conditions, because of interpersonal discrimination. How does this get under the skin? How does it work to produce poor health? Well, we all experience stress. We all have a fight or flight response, right? And this fight or flight response, it's a common characteristic of life. It helps us to be more alert in difficult circumstances, and it helps us sort of fight the negative conditions of life. But however, when over the life course you experience significant amount of stress, that starts to deteriorate your body at a higher rate. And that's what we call the allostatic load. It's a higher wear and tear in the body because of life course stressors. So stressors that are pretty much present all the time, such as poverty, pretty much, any conditions that I've talked about, right? They are chronic, they are hard to escape, therefore they cause stress over your whole lifetime. And that starts affecting your brain, that starts affecting your heart, that starts affecting pretty much every system in your body and wearing it and tearing it at a higher rate. So your heart rate is elevated, your pancreas starts dysfunctioning, so you're more prone to diabetes and all these other conditions that make people more prone, again, to have COVID-19. Furthermore, people of color are also more likely to have a lack of access to healthcare. As you see in the graph, people that are in poverty and those who are Hispanic or Black also have a lack of healthcare access. And this is data from 2017. So it's pretty recent. And this is a problem that has existed. It was sort of alleviated a little bit by the Affordable Care Act. But now that the subsidies to the Affordable Care Act are pretty much non-existent, we are back to a high level of uninsurance in the United States among these populations. And even if people have insurance, they also encounter bias in clinical settings. So people of color, Blacks, Latinos, Native Americans, they find that their physicians and other health providers do not give them the best of treatment. So there are disparities in care that are found for pretty significant conditions, including cardiovascular care, cancer diagnosis, diabetes care, kidney disease and kidney transplantation, pediatric care, mental health, and many surgical procedures. So minorities are more likely to receive undesirable procedures such as amputations. They are more likely to be put on dialysis rather than to be put on a transplantation wait list. So minorities sort of also suffer of a disproportionate treatment where state-of-the-art treatment is not always an option. And even though we don't have, hard empirical data, there's been reports in social media that Black Americans are showing up to hospitals with COVID-19 symptoms and they are turned away. They are given an inhaler and sent home, or they have tried to get tested multiple times and to no avail. And therefore we're seeing higher mortality. So there's not only the disparity in terms of all the living conditions, but also on how patients are treated. And just to add insult to injury, we are also seeing sort of blame shifting, where the Surgeon General, for example, when asked what was the issue, why were Black Americans dying at higher rates, well, his only answer was because they have all these other health conditions, they have all these comorbidities, but he really didn't explain why. And instead, he asked people of color to stop using alcohol, to stop using drugs during the pandemic. Later on, he said he was not talking about specific people, but he mentioned these things when he was talking about the disproportionate rate of minority deaths. So again, instead of pinpointing the issues of structural racism that put people of color at higher risk, we're blaming people with pretty stereotypical advice, right, to stop consuming alcohol and drugs. And same with Van Jones, right? He shared that he has high cholesterol and prediabetes and hypertension. And he said, we're going to have to make big changes in both our public systems and our personal lives. So again, blaming people for their own health behaviors, even though we know that the structural conditions of life for minorities prevents them from, quote unquote, making good decisions. So overall, residential segregation or racism at a structural level, interpersonal discrimination, bias in clinical settings, as well as the lack of healthcare, are pretty much responsible for shaping racial health disparities across minority populations. And of course, that is also highly related to policy and how policy is shaped. And I'll let you continue, Gabe.
Yeah, so a lot of the things that Guadalupe hit on, so on residential segregation, on structural poverty, and so on, definitely have a political and a policy component to them. We also know that despite recent medical and technological solutions that have to do with illness and disease, largely health disparities still remain. So a potential explanation for the persistence of these disparities is that public policy as well as political factors have not been successful in providing solutions that actually remedy these problems. So political actors, institutions, and bureaucracies all have control in determining and in implementing both health and social policy agendas. We also know that political ideology guides how policy is framed, so health policy often becomes ineffective. And finally, this kind of focus on downstream interventions and individual behavior changes, so things like quit smoking, quit drinking, these things have plagued public policy, and they often result in the reproduction of health disparities. So again, political factors play a key role in determining health outcomes. Government type, party ideology, welfare, and other policy implementation all have a direct impact on public health outcomes. So we've seen this with suicide rates being higher in countries that have more conservative administrations. We see this with infant mortality rates being below trend during Democratic presidential administrations and above trend during Republican administrations in the US. We see this with teen birth rates being lower on average in more liberal-leaning states than those in conservative states. And some recent work finds that states that have greater levels of LGBT protective policies in place actually have better HIV/AIDS outcomes than states with less protection in place. So these are things like anti-workplace discrimination policies, school policies, public accommodation policies. And we also know that partisanship, ideology, social services, and state health spending all have a direct impact on HIV/AIDS outcomes as well. So politics and public policy also have impacts on past and ongoing epidemics. This is well established. So for example, spending on healthcare services for those at risk of HIV infection or for people living with HIV/AIDS leads to improved health outcomes. We also know that states, as I mentioned, with higher spending on public health and social services have significantly lower HIV/AIDS cases and fewer AIDS-related deaths. Increases in spending also directly related to HIV/AIDS treatment results in better outcomes. Social factors like housing and food insecurity, so things that Guadalupe mentioned and hit on, are associated with increased risk of HIV infection. Average HIV diagnosis rates increase among people with less education and among those who live below the federal poverty level. And so lack of adequate social policy can lead to deaths in these past epidemics and kind of ongoing struggles here. So with this in mind, it kind of begs the question of what impact these state level politics and state level policy factors are playing in COVID, as well as in racial disparities in COVID. So analysis at this point is extremely difficult because of some kind of glaring data shortcomings. First is that testing is extremely limited, so we're largely underestimating the actual incidence and therefore mortality of COVID. We also know that racial ethnic data is limited at the state level, and in some states it's completely non-existent. So when analysis is run, any impact that these kind of state level political or state level policy factors have on COVID incidence and mortality, or on disparities that we see in COVID by race, they get completely washed away when we introduce testing rates into models. So what exactly do I mean by this? So as of Saturday, so that obviously more tests have been run since Saturday, but for the sake of clarity, this is from Saturday. States on average had a COVID testing rate of 1,684 per 100,000 population. So that means out of the 100,000 people, only around 1,700 have been tested. So states range from a low of 847 in Virginia to a high of 4,813 in Rhode Island. We see some major differences in the states that we're all in right now. So Texas comes in at 47th in testing rate, where we are testing at a rate of 916 per 100,000 population. Mississippi comes in at 16th at around 2,000 per 100,000 population. Utah, surprisingly, is doing very well at around 5th place with 2,853 per 100,000 population. And then Mass is doing great at around 3,200 per 100,000 population. So while the impact of these state level political and policy factors get washed when we introduce testing rates, these testing rates are associated with these different state level political and policy factors. So we see this with governor partisanship. So states that have a Democrat as a governor have higher testing rates than states with a Republican or other governor. This is also true for stay-at-home orders. So states under Democratic governors instituted these earlier than states that were not. They've also lasted longer, or they haven't ended. So Texas is rolling out the phase 1 of its reopening on Friday, for example. We also see this with the positive relationship between social services and state health spending and COVID testing. So as states spend more on social services and state health services per capita, higher COVID testing rates occur. We also see this with citizen and government ideology and testing rates. So states that rank higher on a kind of a liberalism scale for both citizen and government ideology have higher testing rates overall. So with all this in mind, kind of the glaring question that we're stuck with is whether we actually know what the racial or ethnic impact of COVID is at this point. So as of yesterday, Texas reported that 13% of its COVID deaths were Black, 17% Latino, and 36% were white. So as of yesterday, there had been 663 fatalities. And these statistics that I just gave on Texas are only based on 318 of those fatalities. So less than 50% of Texas fatalities have been investigated and have been assigned a race component. But 32% of these fatalities are actually classified as unknown. So a glaring large proportion of the quote investigated racial fatalities in Texas are largely unknown. So if we were to exclude these cases, the disparities increase. So Blacks make up nearly 20% of deaths rather than 13.2. And we're now basing our racial fatality data on only 33% of all fatalities in the state. So this is largely the case across states. So as we can see here, racial and ethnic data is largely unavailable. So I've selected some of the states that we're in, as well as some of the kind of the key states where the epidemic is, or the pandemic is occurring. So in Texas, we have available racial data for only 16% of our cases. I mentioned only 33% of our deaths. In Mass, you have 44% of your cases actually having racial data and 49% of your deaths. Mississippi, surprisingly, has 96% of its cases attached to a race. And as of yesterday, 100% of its deaths have a race attached to them. Today, I think they're investigating 8, so it's not quite 100% anymore. Some states don't have racial data for cases. So New York and New York City and New Jersey all are not issuing data on cases, but they are on deaths. And then some states don't have racial data available for deaths. So Utah is an example there, as well as Virginia. So if we compare kind of Texas, who has 33% of its available racial data, and Mississippi, which has 100%, we get a really a different image of what's going on here. So the disparities look more stark in Mississippi, where the racial data is more complete. Texas doesn't look as bad, but again, it's only based on 33% of the racial data. So then what does all this mean kind of collectively? First, we know that because testing is limited and because racial and ethnic data on the confirmed cases and deaths is limited, we're likely grossly underestimating the actual racial and ethnic disparities that are occurring right now with COVID. Second, we know that states with higher rates of testing show higher incidence rates. They also show higher mortality rates, and they show greater disparities in incidence and mortality between whites and groups of color. We can see this, for example, with the figure on the right here, where as testing rates for COVID increase, the Black-white mortality gap also increases. So when we're testing at a rate of 5,000 per 100,000 population, the Black-white gap in mortality is much higher than when we're testing at a rate of 1,000 per 1,000 population. And then finally, the major takeaway is that states that have more complete data on race and ethnicity are also showing greater disparities in incidence and in mortality between whites and groups of color. So collectively, we can take away that, yes, racial and ethnic disparities are occurring. Comorbidities do not fully explain what's happening. They don't fully explain what's occurring. Some of these kind of state political and policy factors are definitely in play, but it's hard to say what the play actually is at this point because of some problems with data availability. And finally, until states kind of ramp up their testing and their surveillance processes, we're probably going to be continuing to underestimate the racial and ethnic disparities that we see. So with that, we'd love to kind of open up for Q&A or any discussion. I can be reached at the email here, which is the Mississippi State email. Guadalupe's email is shown as well. So we're happy to take kind of comments or discussion by email as well. But with that, I will stop the share and we'll open it up for some Q&A.
Yeah, so thank you all so much, or thank you both so much. That was so good. I'm so proud to know you. So I just wanted to say to everybody who has questions, we're going to do it sort of the way that we do in BKC Fellows Hour, which is that if you have a question, please message me in the chat and I'll add you to the queue. So right now we have Elizabeth, then Mutali, then Leo, and then after that, if more folks have questions, then just send me a message and you can feel free. So Elizabeth, let's hear from you.
Thank you both for a wonderful presentation. Thank you, April, for organizing. My question is, and obviously, I understand this is very focused on the US, but given, the sort of social and political and all these other factors that you've outlined and the systemic nature of those on the sort of impact and the types of disparities we're starting to see, and recognizing, of course, that the data is incomplete and still kind of unfolding. Do you know what's going on in other countries and how that sort of bears out on, on some of the data we're seeing in the US and what it tells us about, the nature of the disparities?
So just as a beginning thought, other countries do not collect race data as much as the United States. So that is an issue in itself. But what we know from places like Australia or New Zealand is that Indigenous populations are more affected than non-Indigenous populations. And in Europe, again, race data is really scarce. So we don't know exactly in terms of race disparities what is happening over there, but we do know that people who are more socially disadvantaged have been sort of the hardest hit of the pandemic. But unfortunately, like I said, nobody measures race data like the US does. So it's hard to tell if this is sort of a major or a global phenomenon. My educated guess is that it is, because, you know, sort of white supremacy is global, right? So my guess is where there are minorities, they are the most affected in this pandemic.
Yeah, we also know in some places that collect data on socioeconomic status, for example, most countries do collect that in a similar way to the US, and we see definite disparities there. And so if we kind of extrapolate there, we know that communities of color are more likely to be disproportionately impacted in that regard. And so we kind of could expect that some of the racial disparities would be present there as well. Kind of on a testing point, most countries are testing at a much higher rate than the United States is. And so I think we kind of have a clearer picture in that sense of what the impact is, especially with like Australia, New Zealand, like Guadalupe mentioned, and affecting Indigenous and lower SES status groups there, where the testing rates are higher than what we're seeing here in the US.
Mortality, you're up next.
Hi all, thank you for a great presentation, and April for getting us together and making sure that this happens. My question is around policy, and specifically how through this presentation, any interventions or strategies that those of us that have access to policymakers could engage to tell the story. And it really comes from a talk that I saw Ruha Benjamin give on white mask, black faces. And she coined this term of social determinants of health, which I found really compelling because I knew that it was something that I could go to Black and Latino legislators with and really get them to understand. But as I sit here in New York, our governor had made a statement yesterday, which he doubled down on today, where he was speaking about homeless populations and how they were not respecting transit workers because they were sleeping on our train system. And the truth of it is these homeless populations were also, just anecdotally looking in the pictures, Black men. I live in the city, I know that they're Black men with mental health issues. And so, and we don't know whether they've been impacted. So I would really, I really enjoyed the presentation, but I'm thinking in a situation where you have 3 bullet points, 2 minutes, how can we create like compelling stories to try and advance some of these policies that you described?
Yeah, I mean, you definitely bring up some important points. I think like the point that needs to be hit home is that we have got to ramp up our testing procedures. And so you can look at, in Texas, for example, testing is kind of largely determined at the county level, although the state health department does have some involvement. But if you look at the testing rates at the county level across Texas, some of the rural counties have massively higher testing rates than some of the other counties. And so we know like what the actual impact there in those counties or in those places that have higher testing rates are. So I think that's the first point, is that that kind of from what we do know about testing and the data that's available, we know that when testing increases, we have a more clear image and a more clear picture of what the actual impact is and how that disproportionately impacts and affects people. To your point on how homeless populations are being impacted, right? So we know that in some cities across the US, they've created kind of homeless camps to try and have instituted some testing there. And so programs like that, I think, are largely effective in being able to identify and find help for those who are homeless who have been impacted already, and to kind of be able to surveillance and maintain what's happening to a better extent. We also know, I forget where this happened, but there's a clinician who essentially took it upon himself to kind of roll out this testing of homeless populations, and he was confronted by the police. I can't recall if he was arrested or not. And so we see that efforts to do these types of things get shut down by those in authority and those with control. And so I think kind of also advocating for protection of people to be able to do these programs if they have the resources to, or to roll these types of things out are important as well.
And another thing is, I heard the conference this morning, and, it goes back again to the blame shifting, right? Instead of taking responsibilities for the material conditions of these populations, the easy thing to say is like, well, they need to be careful. They need to do what is right. But of course, you need programs. If you want the homeless population not to further spread COVID, well, then you need to give them adequate shelter, right? I think in California, the governor is doing sort of a better job in terms of placing people, in hotel rooms, sort of to avoid the further spread of the infection. But like Gabe said, it depends on the type of policymaker and whether their financial interest sort of weighs more or weighs less than the actual scientific knowledge.
Just as a quick follow-up, because I know other people, I was wondering, and thank you for your answers, but I was really looking for strategies. So is it that we make the argument that taking care of these social determinants of health, because they understand that, right? You need these like little phrases. If we make it an economic argument, like if we don't take care of this and we have to shut our economy down again, that's more expensive than finding adequate housing for the homeless. Or is it that type of thing that we need to do? Because I sit in New York, we have a Democratic governor. This just sounds like such bleeding hearts. It sounds expensive. There are other right-wing interests that would say, just take care, Van Jones, just take care of yourself, you'll be fine. But I'll email you too. I don't want to take over the conversation.
Yeah, just really quick. I think that the main strategy here would be for governors. We cannot, say the federal government, but governors need to take and ramp up the testing, especially in communities of color, right? So we need to ramp up the testing and we need to ramp up the surveillance. And the surveillance means sort of isolating the cases that have been confirmed, following up with all the contacts for those individuals and testing and sort of following up, which has not been done in the US at all, right? New Zealand literally has COVID is over in New Zealand, right? But they did a lot of testing, they did a lot of following up. So if we know now that that minorities in the population are more affected than non-Hispanic whites, then we need to ramp up the testing and the surveillance in those communities. Of course, that comes with its own set of issues, but that's the first thing that needs to happen. Because without testing, we don't know, like Gabe said, we are massively underestimating, because we don't have the race data, we're massively underestimating the disparities. But another thing is that we don't know the actual denominator to know exactly how many cases and how much deaths we actually have. Because COVID is killing people from not just in terms of respiratory distress, but also stroke, kidney disease. It's having sort of major effects on the body. And now in autopsies down in February, they're discovering that those folks died of COVID-19. So we have, you know, not only a lack of race data, but the data that we have is massively lacking. So testing, that would be my main answer or my main strategy.
Thank you.
I will just add one thing about your point on like kind of a buzzword with the social determinants of health. I don't know. So I think I'm a little, I'm trying to be careful what I say. So we've had like healthy people since like the 1980s, and every healthy people rollout every 10 years is about addressing these social determinants of health. And every 10 years we roll out, we have a new healthy people. So Healthy People 2020 is about to expire. That I anticipate a Healthy People 2030 will come out, or 2040 maybe. And every time it rolls out, it's all about addressing these social determinants of health and these kind of guidelines and milestones that we're supposed to make by the end, and we're not making them. And so I don't know. So I don't know that. I don't know what I'm trying to say, I guess, other than that it's not really a new idea. And I think that oftentimes policymakers kind of use the concept just as like oh, but look, these are our goals. We're trying to address these social determinants. Look at Healthy People 2020. Income inequality is a determinant of health, and that's one of the things we're trying to address in Healthy People 2020, right? And so I think policymakers are able to use that to kind of to avert actual change, I guess is what I'm trying to get at.
And another thing that policymakers are not paying attention to is that most of the people that are deemed essential workers right now are minority people, right? So your grocery workers, nurses, even physicians. You know, we have a high proportion of physicians in the US who are foreign born. And all these folks who are basically on the line, you know, the United States would rather have them working, especially grocery workers and people in non-medical professions, than helping people with a stipend while the pandemic passes, right? Instead, we put our trillions in the big business area rather than helping people stay at home and stay safe. So, you know, there are many things that can be done from a policy perspective, but the political will is not always there.
Thank you.
Thank you both. Leo, you're up next.
So hi everyone, thank you very much April, Guadalupe and Gabe for this excellent presentation, and just the fact that we had that conversation and we can also expand the conversation in our networks is already a fantastic step. I hope that you will agree also maybe to share some of your slides. That could be a great way because it gives like very interesting data that we can also put in connection in other countries. First, I wanted to address very quickly the question of Elizabeth around thinking about other countries. So obviously in Western Europe, and now I'm based in Spain, the fact that we have military quarantine, we definitely have police violence as one of the factors that is making the situation, the racial divide much worse. But apart from all those lack of testing and also access to hospital, one of the way to reflect transnationally about the topic is the way we use the American research and the American racial vocabulary and literacy as a platform to address what we have colorblind or non-racial way to address those issues in our country. So I think that it would be very interesting to use those data and to see how much the American news around racial disparity is used in countries that doesn't want to use race as a factor to see the impact that it has on the policies. I wanted to have two things, and it's a little bit a continuation of strategy. Can we use first the World Health Organization as a platform, since it's becoming the first consultation network, to use all those data and to speak about the lack of testing, for instance, maybe creating an app or tracking app of person of color being refused to get access to testing as a way first to do advocacy, but also to use that platform as kind of a toolkit to speak about those things. I'm working a lot with favelas in Brazil, and many of the policymakers and people working on the field are using the WHO organization because it's one of the only giving guidelines in Portuguese, for instance. So when I know in the US, the English is and Spanish are such languages, but in smaller languages countries, like it's so important that all those translations are being made. So can that be the step first to knock the doors of WHO and put this idea of racial disparity and testing as one of the priority, and maybe to use a track system? And I have a provocation, and it's a strong provocation, but I think it's an important conversation. Since we are now in a medical genocide, can we also reflect differently around biological racism and race as a biological factor? Not saying that race is biology, but finding a way to make it much more complex than just stating that race is not biology, knowing that now we have all those issues connecting to health and to racial disparity. Knowing that some mixed race people, for instance, they cannot have access to blood or to different organs because their genetic combination is so strong that they can be dying for the COVID also because of lack of access on research and their health components. So I don't know. I'm thinking around that. Do we have to push, as people working on race and technology, a new way of reflecting on race and biology to think it differently? Thank you so much.
So you bring up an interesting point. The problem is that we are sort of in a dangerous time when it comes to race research, right? Because now everybody's doing Ancestry.com and 23andMe and all these things. So we are sort of back in an age where a lot of people are essentializing race, where a lot of people are starting to think about race as a biological sort of a distinction. But the risk that we run if we accept those terms is that we go back to justifying sort of violence and further oppression of some communities based on these quote unquote biological factors. So I think that that would not be sort of the way to go in terms of advocating for further attention to racial health disparities, because those are grounded in sort of a socio-historical context that is much more broad than just, you know, what you look like in terms of phenotype. So I think that that would not be sort of the best strategy, at least in the United States. In places where race is not, it's important because people of color all over the world have sort of a lower life conditions or lower level material conditions. I guess addressing the socioeconomic inequality would be the first step. But I would be advised strongly against anything that infers that race is biological, because that's a pretty dangerous slippery slope from, okay, what do people look like? Do we need to ban them from the country? Do we need to, which we already see, right? With immigrants and other populations, we're already saying, well, if we close the borders, maybe things will get better. So it's a very sort of dangerous step to sort of go there to the biological aspect.
Yep. So Dragana, you're up next.
I think Leo wanted to say something.
Oh yeah, please.
No, sorry. It's just I wanted to go back to the WHO because I think it's an important question. And should we create apps? And to go back to also Mutale's question about strategy, should we create apps to track this lack of testing or this lack of access for the POCs to hospitals? It's simple, but yeah, should we try to get those people and do that?
Mm-hmm. Well, I think that the technology sector does have an important role to play with in terms of surveillance, right? So they're rolling out surveys asking people if they had any of the symptoms, you know, every few days, tracking people that actually have confirmed cases, and sort of how they have interacted with social networks right before they knew their diagnosis, right? I think that's the place where technologies and apps would sort of make a wonderful addition to the surveillance process. I don't know about testing, because in order to test you, you know, they have to insert the massive swab down your nose. So that probably is not going to be a DIY process anytime soon. But in terms of surveillance and sort of keeping an accurate count of people with symptoms, I think that's where technology would play a good role.
Yeah, I think we also have to acknowledge some of this has already been rolled out by certain hospitals, for example. So some hospitals have made kind of these evaluation apps or evaluation questionnaires. And so I think some people have already become kind of disillusioned to using these because they fill these things out saying yes, yes, yes to all these symptoms, right? But then because they say no to I wasn't out of the country or no to I haven't been in direct contact with the confirmed case, they're denied a test. And so I think in any kind of rollout that we have with the things that you're talking about, I think we have to, and this is totally beyond my scope. I don't do technology or rolling out apps or whatnot. But I think that's something that has to be considered of what technology has already been used and how have people kind of been burned by it or have a lack of trust in filling this questionnaire out again. And so I think that's an important conversation to have as well.
Yeah, and we understand that, with apps, there comes issues of surveillance and tracking of certain populations. So it becomes a little problematic. But in my opinion, we are already surveilled in so many ways, right? Like when people received their stimulus check, they were surprised because, oh, the government knows my bank account and, all my information. Yes, unfortunately, in these times, I think that our data is already out there in so many ways. So I don't know if the implication, I am aware of the implications, but I don't know if any apps to track the pandemic would make it any worse.
Yeah, I'm seeing some of the comments you're giving in the chat as well. And Leo, your point on tracking clinicians or practitioners who are refusing access, right? I think we're seeing that happen in other spaces already. So Black Twitter, I think this is kind of at the localized level, right? This is occurring. And so I think a lot of these communities are already kind of aware of this and are doing this in other ways. But yeah, I definitely think that there's potential there. Just as far as how or what, I don't know that I have an answer.
Dragana?
Thank you. This is actually exactly the question I was going to ask. Thank you for organizing this. Thank you, Guadalupe and April and Gabe. Guadalupe, you mentioned how minorities are, when looking at this globally, how minorities are going to be disproportionately affected. My question was about contact tracing. Whenever we have structures like this that are built on white patriarchal systems, then you're going to have people who are immediately, it's going to create a gap of power asymmetry and gaps between advantages, stigma, access to healthcare. So I was hoping we could, I know that we're out of time, but I was hoping maybe we could at least develop or unbraid maybe some of these ideas for what could happen to people on lines of race and ethnicity with a system like this. What should we look out for? What should we advocate for? What should we research?
So are you asking about what would be some of the dangers of tracking systems?
Yes, in this context, yes.
Mm-hmm. Well, of course, the dangers of tracking systems, like you said, in a system that is based on white supremacy, right? Right now, I think the danger would be for those populations maybe to be isolated or the opposite, right? To sort of let them develop a natural immunity, right? Sort of let the pandemic roll through and see what happens. But I don't know if in this case, the risk outweigh the benefits. I think that the United States is such a big country, people are moving constantly, that I don't know if without tracking, we're ever gonna be over the pandemic in terms of, from the epidemiological perspective. Of course, that care is dangerous, especially for people of color. But I think that also this goes back to the whole racial health disparities. If we don't know what populations are being most affected, how can we help them, right? So again, it's sort of a weighing of what are the risks and what are the benefits.
If we have systems like this, but I'm so sorry, just a really quick comment. If we have systems like this that are based on a smartphone, for example, not everyone has access to a smartphone. Mm-hmm. Not everybody can afford data. Not everyone has access to data throughout the day. Sometimes whole families share one phone. So this data is going to be, yeah, and this is what I'm concerned about. How is this going to disadvantage groups on lines of race and ethnicity in this country? How is this going to disadvantage minorities?
Yeah, so I think everything you just mentioned obviously is evident. But what I was going to mention is that I can't remember if it was in Seattle or if it was somewhere in Washington. What we saw was essentially like quarantine camps being created in minority communities. So very early on, like a hotel it wasn't a hotel, but essentially a camp was placed in a predominantly Black community. And at the time, it was a majority white population that was being diagnosed. And so they were being relocated to these camps. And so I think if we do kind of this contact tracing in this ways, one kind of the unintended consequence, or maybe not unintended, right, is that if we do kind of these quarantine type camps, they often are going to be placed in these communities. And so we're now bringing the disease right to these communities that are kind of more people per square mile, and so the disproportionate impact there is I think something also that we have to consider. And yeah, I would just echo all your points about if we're doing an iPhone or a smartphone tracking device, how do we get the access to those who don't have an iPhone or don't have a smartphone, and so yeah, I think that it's definitely an important conversation as well.
Yeah, and I mean, there is a digital divide. And I think in this case, also rural populations would be hardly hit, right? We're seeing it now that all of us are teaching online, that some of our students don't have access to the internet. So of course that is an issue. And I'm not saying that that type of surveillance data would be the only one, but I think it could mean that it's a good complement to the surveillance data that is being collected by the government. Because obviously we're seeing that there's massive flaws in the data that is being produced. So maybe that would be an alternative to give us better data to track the pandemic.
So unfortunately, we are out of time technically. We didn't really set an end time. But I want to give Afsana and Beatrice an opportunity to ask their questions. So if you could both ask your questions that you have, and then maybe Gabe and Guadalupe, you can perhaps combine them or respond to them via email. But I'd love for them to at least get their questions out there. So Afsana and then Beatrice, please proceed.
Oh, okay. I mean, if you want, I can just leave my question, but I'll put it there. If you have time, you can answer it. I just wanted to, first of all, thank you for all the information, and seeing it visualized through the data you've gathered is really interesting, and for me, it's been really informative. I wondered if you have more that you could share about the minorities we have within our minorities, whether it's the communities of color with disabilities, queer communities of color, the immigrant groups, and how this impacts them beyond the impacts we're already seeing on communities of color. And the other small question, if you don't have time, please don't answer it, is about the impact of disinformation targeted towards communities of color, and how that's impacted, or how you've seen that affect your research. Thank you.
Thank you.
And Beatrice?
My question is more about the financial burden that comes with COVID-19. Since a lot of immigrants of color and communities of color don't have access to like healthcare in general and insurance, how that also might be a determining role whether or not they get tested. I've heard things about just like $2,000 worth of like testing, lab analysis, to we're not speaking about how a night at a hospital is like damaging financially. So I was wondering if you saw that in your analysis.
So we haven't seen that in our analysis, but we know, like I showed that chart about levels of uninsurance, right? So we know that African Americans, we know that Latinos are highly uninsured in the United States. And right now, the sort of the figure that people are throwing around, for people that require hospitalization for COVID-19 without insurance, it could be a bill up to $75,000. Right? So that's an impossible bill to pay for, especially for people that, you know, are already sort of strapped economically. So we are seeing the effect on, like Afsane said, in terms of immigrant communities, not only because of cost, but also because they are afraid in terms of the socio-political climate in terms of immigrant sort of surveillance, right? So it's not only affecting communities in terms of it's affecting communities in terms of testing, but also receiving adequate treatment, timely treatment. So that definitely could play out in terms of why we're seeing higher rates of death among Latinos, for example. Gabe?
Yeah, so in the context of testing, the analysis actually does show that states that have higher proportions of those who are without insurance have lower testing rates. So this is exactly what you're talking about, that if you're uninsured, you can't afford a test. It also shows that as like lack of access to primary care increases in the state, the testing rates are lower. I mean, that's kind of a no-brainer there. So yeah, I mean, I think we are seeing it to some extent in the data, and what the kind of the lacking data that there is, that increased unemployment and increased lack of access do kind of result in lower testing rates. And so I guess I would kind of put an asterisk on that earlier point about we need to be advocating for more testing. We need to be advocating for cost-free testing, and we need to be advocating for testing in kind of these hard-to-reach places as well.
And probably cost-free treatment as well.
Right. Yeah. Of course. Absolutely. Yeah. The point on right, if you're kind of double minoritized, is there a differential impact? I think anecdotally we know that there is. So we know, for example, in queer communities where like smoking occurs at a higher rate, we know that if you smoke, that kind of plays in a comorbidity. And so there's some structural things there that cause queer communities to smoke at higher rates. And so yeah, I think we do see kind of a disproportionate impact of when we take kind of an intersectional approach to the disparities that we're seeing. I don't know much about the disinformation question, other than kind of the I guess the false cures that have kind of been thrown out, but I don't know so much that they've been targeted more to minority communities or not. But yeah, I think disinformation right now is kind of rampant. I mean, the president gave some, so it's what can you say?
Yeah, I don't know if misinformation of the type that is happening in terms of, I don't know, drinking disinfectant or injecting it. I don't know if that is particularly affecting communities of color, because we're seeing these more in people that consume conservative media. So we don't know if there's a difference there. Of course, that's a very interesting research question, but I'm not sure that the disinformation or misinformation particularly affects people of color. But yeah, there are definitely people out there drinking Lysol, so it's a problem.
Okay, and on that note, thank you all for joining. Please join me in giving a virtual, or I guess it's real, but it's on virtual round of applause for Guadalupe and Gabe. And again, thank you. This was so wonderful. I feel like I learned so much. This was a great investment of my time. So thank you for joining us.
Thank you for having us.